I think we have people kind of all across the country right now dialing in. For those of you who have not met me, my name is Lindsay Dahl. I'm the Chief Impact Officer here at Ritual. And I'm really excited to be co-hosting today's panel for a couple different reasons. On a personal note, I have personal connections both to Jessica and to Jeanette. We were just talking, we've been working together, Black Women for Wellness, the organization she'll tell you about. We've been working together for almost 2 decades now, working at the intersection of social justice and environmental health. So it's really fun to see you on the screen and have you here as part of the Ritual community as well. And Jessica and I, incidentally, she was the on-call backup doula for my firstborn, and actually taught me one of the best things I ever learned about myself. So indulge me just for 1 second to give you a nod, Jessica. You may or may not remember this conversation. She was talking about different ways that people show up during their birthing experience. And she talked about animals and how some people are like dolphins and want to be around a few others, and some are. And then she was like, and then there's cats who want no one to be around and not to look at them. And I was like, I'm a cat. After I had my first, now I'm always like, even when I get a cut, I think about Jessica and I'm like, I'm a cat. Don't look at me. I want to be about myself. So anyway, but today is not about me. I just want to say I'm really excited, based on who the panelists are, to have a really important and rich discussion about Black maternal health and the Black maternal health crisis. So there's the positive and the negative framing, and we'll kind of get into all of it today. You know, it's important for Ritual as a business that works at the intersection of a lot of these important issues to internally hold ourselves accountable to and learn about important issues that are facing the communities, both within the Ritual community, our customer base, and the world at large. Because the more we know, the more we can mobilize ourselves and our community and the power of our business for a change. So with that, I'm going to pass it over to my co-host and colleague here at Ritual, Alexis, to introduce herself, and then we'll meet our panelists and dive into a nice Q&A.
Hi, everyone. My name is Alexis. I am an engineer here at Ritual, and I'm really happy to be here co-hosting the panel with Lindsay, with all our wonderful and informative panelists as well. Well, I'm here because Black Maternal Health Week is very important to me, just on a personal level too. I did not carry my twins, but my partner did, and it's something that I know that personally I will probably do in the future eventually. But even beyond that, knowing that I know I have friends, I have family members, I have siblings who have been through this birthing process, and it's pretty intense. And I think we don't really take that into account a lot, especially for those who bring new life into the world. But yeah, it's important to me because as someone who sees that in my community every day, I want to be able to be informed and to have my learning and do my learning as well. And so that's why I'm here. And with that, we're also going to pass it over to the panelists to introduce themselves. I'll just introduce one at a time, and we could go from there. And then we'll get into some questions that the DEI committee has so thoughtfully brought up for us to ask the panelists. So first, I'm going to start with Jessica, because you're on my left. I'll start with Jessica. So can you please just introduce yourself, the work you do, and why this is important to you?
Yes, can everyone hear me? Good. Hi, I'm Jessica Diggs. I am a licensed midwife based in Los Angeles. I was a doula for a very long time, which is how I know Lindsay. I love what this work that I've been able to do for 12 years now. I got into this work from an education standpoint. I actively was not trying to get pregnant. Still I'm not. I was 19, and I was fixated on the fact that friends around me knew nothing about their bodies or why their birth stories unfolded as they did. And I wanted to answer those questions and be a source of just education for friends and families. And then I fell in love with what doulas do, and wanted to be at birth. I did that for a while, and then really wanted to be a provider to actually give a sense of choice to people and not just talk about the options for choice. So now I am a home birth midwife. I am a gynecologist, essentially, so I do a lot of holistic gyn work and insemination for folks. And then I also work at Moxie Care, Moxie Birth, which are a birth center in South Pasadena. So I do a lot of things, but at the heart of all of that is really making sure people know their choices around reproductive health, and have options. So I'm excited to be here, excited to be on the panel with you, Sarah, and yeah, get to know more about the work you do, Jeanette.
Excellent. Thank you so much, Jessica. And with that, we'll pass it over to Sarah to introduce yourself. Same question, the work you do, why you love it, why you think it's important.
Well, I can say part of the reason I love the work that I do is folks like Jessica and Jeanette, and I like get to fangirl them. My name is Sarah Ferguson. I'm originally from Los Angeles, California. I currently reside in the Bay Area. I am a doula and currently a student midwife. A lot of my work surrounds abortion education and support and political education. Okay, Bay Area, I love most hyphy part of the community. Thank you in the chat. I really love talking about reproductive care models and how do we create culturally relevant spaces for people to be cared for, and how do we change the discourse around what care looks like and care expectations. And so I love showing up for Ritual because y'all make that process just so much more seamless and like accessible for people. And so I'm grateful to be here. Check.
Thank you so much, Sarah. Appreciate it. Very nice intro and welcome to the panel. And last but not least, let's introduce Jeanette Robinson-Flint. I'll hand the mic over to you and feel free to tell us about the work you're doing and why it's important to you.
So, Jeanette Robinson-Flint, and I was born and raised in Chicago and then migrated out here one winter, right? It was like 100 degrees in Chicago. No, 100 degrees difference between the weather in Chicago and in Los Angeles. So here I am. I'm the executive director of Black Women for Wellness, and I love this. It is super duper special working with Black women who are passionate about organizing and mobilizing our community, about creating change, and about using their imagination and vision to see a new world for us. Our mission says we are lifting the experience and voices of Black women and girls. And when I watch and witness Black women and girls use their voice and practice that empowerment, it makes my day because it lets me know we are headed in the right direction. We've been doing this for about 25 years. It all started with, I think, two moments in my life. One was when the six of us who started Black Women for Wellness were in China at the 4th World Conference on Women, and we thought, oh, we got to go home and do something. We cannot be unorganized. That was in 95. And then the other was when a woman named Catherine Hall, who's now Catherine Hall Trujillo, came to town with us to start the Birthing Project, which asked us to mentor a pregnant woman until the baby was 1 year old. So the group of us who started Black Women for Wellness, it was 6 of us, we're mentoring 23 women between us. So we got a lot of new life on that Underground Railroad to new life.
Wow, thank you so much for that introduction. And it's really powerful to hear stories and the history of everything. So look forward to hearing more of that.
Mm-hmm.
Yeah, so with that, Lindsay, I'll kick us off with the first question, if that's okay.
Mm-hmm.
So yeah, we're going to ask a couple questions to the panelists. We're going to give everyone a chance to chime in, even if the question wasn't asked to you. And then for all the audience members, please keep your questions to the chat, or for afterwards, we're going to try and have some time at the end where people can to chime in and ask them and talk some more. All right, great. Well, with that, the first question is actually going to be for everyone in the panel. So we'll start with whoever wants to start first. But the first question is just about basics. For those who don't know as much about Black maternal health, what is the Black maternal health crisis? What is it in a nutshell, and why is it impactful right now?
I can start.
Go ahead.
The crisis is the statistics, right? Mm-hmm. So the data says that Black women are 4 times more likely to die giving birth. And the data says that Black babies are 11 times more likely to die before their first birthday. Well, that's a crisis. It's a crisis for each and every single one of those people who make up that statistic, but it's also a crisis of our community because it means that our future is threatened, right? It means that our health is compromised. So that is the crisis or the challenge to that crisis. How do we eliminate that health disparity? So when we talk about what is going on with Black women around maternal and infant health, our stats are comparable to or at the same level as a developing country, right? But yet we are in a space where allegedly we have access to healthcare, we have clean water, we have technology, medical technology, we have personnel, but the question is, with all of those gifts that we have here in California or in the United States, then why is it that Black women are still suffering that health inequity?
Excellent. Thank you.
So well said. I would say adding to that is the conversation around why and the fact that this is very much preventable. Diving into the long history of racism in this country kind of leads us to see why that there is that disparity and why it's not actually changing despite the alleged wealth of this country. Because racism in this country has not changed. It has not improved. And despite what you may think, we're seeing that still reflected in the numbers and often worsened. So that's the other piece that kind of lies under, is like not the individual pieces of health, because we see these stats don't change with education. It doesn't change with finances. So yeah, I can't even get there. Any of the socioeconomic, actually higher educated Black women have a worse outcome than lower educated Black women and lower educated socioeconomic statuses. So it doesn't improve even if there's some class jumping or improved socioeconomic status. So it's clearly related to race, and that hasn't improved in this country.
I think to like segue and add on to that, it is important to know, and the last time I was here, I hate the narrative that like Black women, we are not dying. Like there are institutional and like structural things that are happening that make care inaccessible. And I think Jessica like spoke to it perfectly. Like there is a issue with like the discipline of like obstetrics and gynecology, and its inception has always been based on the fact that like Black birthing people have a different relationship with pain and have a different relationship with labor. And we see these things play out in like the medical room on a day-to-day basis. And it's really like important that we put the onus back on the institution. Like absolutely Black women, Black folks and Black birthing people are gonna have to do the legwork to like keep ourselves safe initially, but there is like institutional structures and violences at play that are far longer and outstanding than like someone who's been alive for, I don't know, 15 to 45 years. That's a birthing person. Like these are 100+ year old problems, and we need to be very clear about that part of this course.
Sarah, can you pull on that thread a little bit more, just for anyone who's newer on the call? When you talk about the relationship between the Black community and pain, can you like hum a few more bars of we can kind of infer what you mean by that? But I think it'd be helpful for all of our education to know more.
Absolutely. So it is important to think about things as like disciplines, and like a discipline is a body of knowledge that is codified and designed to be passed down generation by generation that holds on to what it is. So the father of gynecology, James Marion Sims, was originally, I don't know what the proper word is, lifted to be a support to enslavers, to make sure that Black birthing people were able to go back to labor as quick as possible. During that time, Black birthing people had specific problems with fistulas. When you're trying to extract labor from someone, rest is not your priority. And so the medicine that was created around that is what we know is like modern gynecology and obstetrics. And so as a discipline, it is very much related to, hey, I'm not actually interested or based on like your holistic wellness or the fact that I acknowledge that you have a recovery period, I am trying to get you back to labor as quick as possible. That same school of thought has been passed around to, you know, most gynecologists that we know and probably love and like are in our communities. But as a discipline, as a school of thought, that is the original intent of this medicine. And so when it does not work for Black birthing people, we have to say like, hey, there's probably something very wrong with the foundation here. And as a community, unfortunately, sorrows and prayers are like not enough. Like there has to be a structural reckoning around, hey, we need to reassess what our beliefs around the bodies are and what we know about them. Just did I hit it all?
Oh yeah, I would say in addition to that, in addition to like what I call it, his research, his torture, he also believed that Black birthing people had a higher pain threshold than white counterparts. And so that has been literally written into modern textbooks today and believed by doctors today. That's creating the problem of like not listening to Black birthing people when they're describing their pain tolerance, their pain threshold. And thus when people are bleeding out internally, they're kind of being overlooked because it's like, no, you're just fine. And that has also contributed to some of these outcomes.
Can I just add real quick? I want to say the names of the 3 women that Marion Simmons tortured. Absolutely tortured. So they were Annika, Lucy, and Betsy. There is a conference every year in Montgomery, Alabama, that celebrates those 3 women and calls them the mothers of gynecology because it was their pain and their suffering that helped them develop the tools that they use now for gynecology. You all are absolutely correct. Folks do not listen to Black women, and they judge Black women differently. If we talk about Kiara Johnson, Charles Johnson's wife, they beg, something is going on, something is wrong. This is a well-to-do Black woman with a husband and a son at Cedars-Sinai in Los Angeles, and she literally internally bled to death. We can say that about April Valentine. Her partner was there also, and he was saying, and she was saying, something is going on here. And she literally last year in 2023 bled to death at Centinela Hospital. So they are not listening to Black women. And yes, the foundation of obstetric care was based in the suffering of 3 Black women, Annika, Lucy, and Betsy.
I think also something that you like brought up so gracefully is like we are losing Black birthing people when they are conscious that they are absolutely not receiving the care that they are supposed to be we're supposed to be receiving. And this is happening in the postpartum period. A large portion of gestational deaths happen in the postpartum period, and they are completely preventable if a provider simply believes that you are experiencing what you said you are experiencing.
Thank you for all that knowledge. Wow, so many tidbits in there that all really hit the nail on the head as far as one Black birthers being believed in the hospital setting, and just the deep root of systemic issues that carry over, really bleed into the healthcare system. With that being said, I think a good question to bring up would be, how can we work with providers, or what are some tools that are helpful in working with providers or other birth partners to really address the lack of cultural competency and some of the bias that really seeps in during that process? Are there any tools or knowledge or tidbits that come from that really help with working with these providers?
I can start with a policy. So Black Women for Wellness passed a policy called the Dignity in Pregnancy and Childbirth Act. And basically what it asked or demanded is that perinatal providers. So it is important that providers, being the OBGYNs or the nurse practitioners or the physician's assistants, but it's also equally important for frontline, the receptionists, and other people who touch a pregnant person coming into an institution, to be trained with implicit bias. Right. So this law was passed in 19, was supposed to be implemented in 20. We know what happened in 2020. So the Attorney General went back in 22, Rob Bonta of California, to say, how are you all doing with implementing this? And the hospital systems, community clinics were like, oops, we forgot to do that. So with that, they went back and started doing the implementation of the implicit bias training. So one of the first things that providers and systems can do is make sure that staff is trained with implicit bias training, that staff knows what anti-Black racism is, that staff knows what misogyny is, and they know what their relationship is to that, right? And there are several different entities now that are doing the implicit bias trainings, and the state holds a report card of some of those trainings. So that's one thing that providers and systems can do to help begin to alleviate this anti-Black racism that people experience when they present at systems.
I love that. I'm so glad you touched on policy. I would say my instance of advocacy is very much more micro and from personal to professional. So I'm like on the ground and trying to figure out how I can do what I can do. But policymakers and holders are always near and dear to my heart. For me, my tips to people are usually starting with your provider. Asking the hard questions, naming things as early as possible. Obviously, access is a whole big contributor to this. Meaning, if you're with someone just based on insurance and you're trying to stay with someone who takes your insurance, it's harder to find the right person always. But from initial contact with people, saying things and naming, like Black Maternal Health crisis, naming that you are nervous or you're concerned about how they will navigate blood pressure, pain, all the things that are kind of coming up as soon as possible, so you can kind of read the room and their response and know, is this a green flag? Is this a red flag? As early enough to switch care. I love and respect doulas, but they're not going to save us. And they are worth their weight in gold. But it's also not on them. They didn't mess up the system. So I would say adding them to your care team for advocacy, for witnessing, for a sense of resource, because I joke, they say they're the mafia. They know everybody. They make or break businesses all the time. So I like from that level, like adding them to the care team is always helpful, but trying to find a care team that gets it. Since probably 18 is when I really start to notice it. People intentionally naming, I'm looking at you to be my midwife, my doula, because you're a Black woman, and it's coming out in initial emails. They're also aware. So like naming that in all conversations with everyone puts people in a space of like humanizing you and starting to like view you like, oh, okay, let me make sure this person feels safe. The medical system is fucked, for lack of a better word, but there are a lot of good humans in it too, and they're inundated with the shittiness of the system as well. So sometimes they need a kind of a snap to moment of like, this is a person having their baby, having an experience they're going to remember forever. Let me see them, and then you see them. So I'm like from that high touch in the moment, naming what you're experiencing, what you fear from the very beginning, getting people on your team that's going to get it, whether it's the Black birth worker, Black doula, Black midwife, Black OB, for the most part, helpful. And then also like normalizing the team who you get the day of, making sure they see you as a person. And if they don't, fire them. There's enough people in that space. Literally, you can change that nurse out. There's several of them sitting behind the desk. Just remove that from your space. So that for me is like those are my tips, just like in the moment tips.
Yeah, I think mine are very similar. I always tell people, like, try your best to hire a great provider, but like, don't feel bad about firing them when you need to, because they're still going to eat, they're still going to have their practice. Like, you are going to have a reproductive outcome that you are displeased with for the rest of your life. And like, although we generally as birthing people are socialized to like be accommodating, this is like not the time to do it. And really understand, like, as a birthing person, your rights and responsibilities are very proportionate. You have a lot of rights in like reproductive healthcare spaces, but you also have a lot of responsibilities. And a lot of that is saying, you're not the right provider for me, or this is not the right dynamic for me. How can I go somewhere where I'm seen? I think as a society, we get really like confused about respect. And respect is like the ability just to like re-see each other as like the people that we're showing up as. And you need a provider that's willing to give you dignity and respect in the room, and understanding that you as a human being are also owed like the dignity of risk as well.
Can I add two more things to that? Just
everybody leave it for Jessica.
Yeah, and those two more things are, one, I would say always have an advocate with you, right? Your partner, your mom, your sister, your brother, not your children, but take someone with you who can hear when somewhat neutral but cheerleader, champion, advocate for you with you. It is difficult to face these systems, bad providers and good providers, alone. Take somebody with you, and have it, if you can, be that consistent person that you take with you, right? So that's one thing. And then the other thing is affirm yourself, claim your power, right? So sometimes you can just put notes all over the bathroom window, a mirror. You can like have notes on your way out the door, but just affirm yourself, because it helps, right? It helps you say, you know what, I'm a wonderful person. I got this. And you walk out the door with your advocate and go face that system. Those are my.
I love that.
I have a follow-up question that's going off script. No one will be surprised, but going where the energy is. I think like naming the power dynamic is really important, which is what all three of you talked about, especially in a moment where you're incredibly vulnerable and maybe don't have all of you're not fully embodied intellectually in the way that you normally are. I think the power is like there's like the power dynamics in literally every touch point within these moments. And everything you said is, I think, really powerful, both at the macro and micro level. For me, it raises a question, and maybe the three of you have a point of view on, when we think about whether it's midwifery or medical school curriculum, especially for the OBGYN field, what's your point of view or perspective on how medical school and midwifery curriculum is properly integrating the social justice intersections of this whole topic? Where are we scale from like 1 to 10, like just starting the conversation, or like it's taken off to the races?
I'm biased. I'm going to know that because I work with an OB-GYN, but I also work with an OB-GYN who is trying to drop the doctor in front of their name because they're aware of that. So I'm on one side of things from current personal professional experience, but that's also rare. It's just rare. It's unfortunate that is a rarity in this country, and that is contributing to the stats, quite frankly. If you look at all other wealthy, developed countries across the world, midwifery care is at the forefront of all of the grouping obstetrical and maternal care, and obstetricians are only brought in for high risk emergent things, and their stats are way better than ours. So because medical school teaches this power dynamic and this hierarchy with true intentionality of, we are in charge in this room and we are over your body and what's happening, typically for a person who's not conscious, which in birth that's not the case, they don't know how to shake that off when they come out of something that is literally brainwashed them to believe one thing. And with midwifery care, we're literally taught that this is shared responsibility. You're an expert in your body. I'm an expert in obstetrical care, but we come together to understand what's going on for this individual person. And even with that, working in OB clinic now, I'm like, finding myself having to be like, tell me what's going on. You tell me what do you want for yours? Here's when I have see people look at me like, you're supposed to be the expert. And in truth, I am, but you are the expert in your body. So I am in a space professionally where I have a OB who gets annoyed when people directly ask for her instead of the midwives on our team when we can answer the same questions. So I have a unique experience of someone doing the work and understanding that these folks are professionals, they're experts, they're great clinicians, and I'm learning from them just as much as they're learning from me. And then I've also been in a space where people keep overlooking the fact that I'm a licensed medical provider by the same medical board in California as every physician. And they're shocked that I brought medical records. I'm like, oh, you chart? Yes, I legally have to. So I think we're in on a scale of 1 to 10, I would say 3, and that's being generous in the state of California. Personally, I'm on like a 9 because I'm in a unique situation.
Yeah. I would say we're not doing well. I think as like a country and as a community, I think there are like pockets where things are more accessible than others. I think as someone who just left LA, like there are no OBs up here that do home birth. And I'm like, okay, well, who do we need to call? What do we need to do? Because in my mind, I'm like, well, there's always a provider. Now I'm somewhere where that doesn't exist. And it's the Bay, and I expect it to be very crunchy and like, what's happening? And now I'm like, So I think about how the political landscape is changing what providers are and aren't learning. As like an abortion provider, I'm very much like, we're not talking about all the things and like full spectrum care, so we're never going to be doing as well as we could be. If you're a surgeon, I expect you to do surgery, and now you're not learning all the surgeries that you need to know. That is going to be a problem. I think about also just like, for better or for worse, American medicine works on the fact that like the care model is not based in self-determination for people. Like, because this authority figure has come in and now they're overseeing this experience, you are like displaced from your own right to like make certain choices and have, you know, the plethora of options accessible to you. I think there are a lot of provider education gaps. Like, OBs are not required to see birth in every setting, but somehow you're an authority. Most midwives, we've been all the places because that's just the nature of the gig. But for someone who hasn't seen birth in all of its capacities, to be an authority is always going to be problematic. And until we rectify that, it's like not going to be resolved. I also think about who gets to be a provider. How do you become an OB? Why did you get chosen? Who picked you? All of these things come up, and we see this in like our provider demographics. They more than likely or not probably don't live amongst most of their patient care population. It's like you're other simply because you're not a neighbor, right? We don't talk about those things enough, and so I think we have a lot of barriers and a lot of fences on both ends that have to be broken down. And I think we see other countries really provide these models very well. I also think scale is something we really don't talk enough about. This is a really big place, and there are a lot of people here. And like, I give OBs a lot of hell, but I'm also very gracious about the fact that they see like 10,000 patients in like a caseload for themselves. And I'm like, well, of course, like you can't offer quality care. My brain, I'm like 4 people in a day. I'm like, I've had enough. Thank you. You know, like,
2 things on that. One, to the work, that was one of my biggest concerns joining this practice. I was like, I'm supposed to talk to people in 15 minutes. I spend an hour usually with folks. How am I going to do that? And it's interesting that you can make it work and be very personal. And then there's people who don't want more, and they've been so used to the bare minimum that I'm like, tell me more. And they're like, just swab me and leave, lady. And I'm like, cool, okay, I'll leave now. And then there are people who do want the time, and so it works itself out. But I was going to say just a random fact about OB, about placing into the specialty in medical school in America. It's based off a test. So for people who want to be surgeons, you have to score, say, a 700 on this test. If you score, say, a 550 or 600, just under that is the slot for OB-GYN, which is a lot of surgery. So a lot of OB-GYNs don't necessarily want to be OB-GYNs. They want it to be surgeons, and they didn't meet the threshold to be placed into a surgical residency program, but they met it enough to be placed in an OB-GYN. So there's a lot of folks who just want to do surgery, and one of the reasons they do have a higher cesarean rate is because they don't care for physiological birth. They never did. So that's a fun fact about a lot of our OB-GYNs here, is that you have to match into that program, and some people don't.
So, and that leads me to say, I think there are three, no, there are more, but the challenge of exclusiveness, and in terms of getting into medical school, the challenge of expensive, right, to get into medical school really narrows the field of who calls themselves MD or who calls themselves a surgeon, right? Midwives have better babies. Okay? And here's the thing also, midwives treat the whole person. They're not specialized. This is one of those, what's that saying? If you're a hammer, a nail is the solution that you're looking for. But that's not, and that's surgeons, right? We're going to do surgery. We're going to medicalize this very natural process called being pregnant and having a baby. So, and that's my vision, right? That we move to a space here where pregnancy is normalized again, and it's not medicalized again. It's not seen as a medical situation where you have to have a medical procedure, that type of thing. Because as long as we have that in this system, as long as we keep this mystery up around birth and the process, then the system is still in charge. And we really need to take systems out of something that is a natural process. And if a woman has a high risk, or if a person has particular challenges with a pregnancy, then yes, let's find a medical doc and deal with that. But if this is the normal pregnancy, let's bring in the midwives and take out the medicalization of pregnancy and childbirth, right? Because with that, the system wins, and the system is not set up for us to be successful, healthy, for us to be self-determinating or autonomous, right? And I actually agree with you all. I had an opportunity to study how medicine or medical care is delivered in Cuba. The doc and the nurse live in the community, and it's 600 to 1. We couldn't even imagine that here in terms of that. But right now, to get into a medical school, if they make it super competitive, they make it exclusive as opposed to inclusive, and then they make it expensive. So we are getting something we don't deserve in terms of healthcare.
I see the chat going on. I want to say like one thing, and then I think we should talk about the chat. And I think, Jessica, you should answer Katharina's question. Yeah, no, I promise.
I'll bring it up to you. Don't worry. Yeah, go ahead. Go ahead.
I also want to say, on top of there being like, there's a global midwifery shortage. Granted, we could make midwifery education accessible and streamlined, but we have to think about there is like, we need 1 million midwives on like a global level to like fill this gap. And so like creating more accessible pathways to become a provider on both ends, because unfortunately we do live in a very industrial world, and more people are having higher risk pregnancies because of lack of care and lack of institutions. So we need both sets of providers, but we need to acknowledge that there are like shortages in both of them. And then I'm going to Jessica.
Thank you, sir. Yeah. So the question that was brought up in the chat by Kat was, do you feel that the insurance system plays a role in accessibility equation?
Accessibility to what? Sorry.
How care is accessible? So yeah.
I think they were asking, well, basically the quote says, "It's wild to me how expensive it is to see home births are compared to hospitals. Do you feel like insurance plays a role in the accessibility in this equation?" And I know you have the good answer.
Gotcha. I was like, I don't know where the chat is. So I can't see anything. That's why you see me like looking weird. Yes to both ends of that question. Home birth, I don't think it's wildly expensive compared to hospital birth. I don't think people have seen their full bill. So home birth on average, I would say in Los Angeles, which is probably going to be the most expensive home birth in the country, is about $8,000 right now. It used to be probably closer to $6,000 a couple years ago. Inflation. It's about $8,000 here, probably $4,000 to $5,000 across the rest of the country. That's it. Your entire care is that, and it's a set rate, flat. You're not getting charged anything else. If you go to the hospital, your IV bag, 2 Tylenols, and the baby blankets is going to be about $8,000, just so you're clear. And then you're also paying monthly insurance premium. So add that up. That's supposed to pay for everything, and you often still have a bill. Most people leave. The average hospital bill is about $30,000 per birth. You're usually responsible for about, depending on your insurance, 10 to 20% of that. So many people are often walking away with a similar bill, if not more than the $8,000. And if any parents have had kiddos, pop in what you paid for, what that hospital bill looks like, so we actually can see the numbers. Because people think just insurance is going to cover it, and that's usually not the case. They're going to cover a portion of that, deductibles, all the things. So it's actually way cheaper to have an out-of-hospital experience, and you actually know what you're getting and what you're paying for. So yeah, seeing Anna's showing up what they paid. So I would say it feels expensive because there's a cash exchange, and it's the same with like me having real cash and me swiping my credit card. It always feels like different money. It's always the same. It feels more expensive, but in reality, you're actually paying for care, and it's going where it's actually supposed to be going. I think that affects accessibility because that is a cash exchange, that people don't have $8,000 just sitting around. They're used to kind of paying a bill over time and breaking it up. For some folks, that feels very, very inaccessible. It is a financial burden for most people. For folks who are wanting that type of care, they often are breaking it down. It's not all due up front. It's throughout the pregnancy, saving for it, asking for a portion at their baby showers. And then we do try. I'm a big believer of trying to make insurance pay for things, even if they claim they don't. So we often will still submit a super bill to them. And most of my clients do get some portion of it reimbursed to make it more accessible. But yes, I will not invalidate. It is a financial burden that you have to pay for healthcare in a country that you are already paying for insurance and healthcare. But that's like a system that has nothing to do with us, and it's one of the reasons most midwives don't play ball with insurance, because what they want to pay me for your entire birth is around $1,800, and I live in Los Angeles. I can't afford to live in Los Angeles if that's what I'm making per birth. And I wouldn't give quality care if I was making that per birth. I would be burnt out, and that's contributing to this healthcare crisis.
I think that's one of the places where we bring policy back into play. How do we create policy where insurance companies must cover home births, right? We recently were very lucky in that we got the cost of a doula covered by insurance, right? Mm-hmm. So that's a policy question in terms of how do we create accessibility. Right now, 99% of the births are in hospitals because health insurance covers hospitals, but it doesn't cover home birth. But it's also because of the culture that we live in now. Also, a lot of times if people have or take an option to have a home birth, then they're criminalized. Especially when things happen, right? And they end up at a hospital. And they usually end up at the hospital because they are caring and concerned and scared and afraid and all of that stuff. And instead of being treated well, then they're criminalized. insurance. So that culture that we live in absolutely reinforces itself with how it pays with insurance and how it gives permission and privilege to MDs that it does not give to midwives, how it pays for all the services at a hospital, but won't pay for a doula, even though a doula really helps out the insurance company by improving the opportunity for a happy, joyous birth, right? Low risk. So what we want to do is have insurance companies pay for doulas, have insurance companies pay for home births, but that's a policy that we have to go to.
100% agree. I think so many people have been wanting this for so long. It's like $8,000 to an insurance company is a drop in the bucket compared to the actual bill that they're paying at the hospital. And yet they usually don't play ball. Like, it's just, they don't play ball. Or if they do, it creates the cyclical issue that doctors are inundated and they're not taking care of themselves. They have to take 1 million people to make a living wage unless they're burnt out and giving shitty care. So for me to be in contract with an insurance company and then paying me $2,000 per birth to make up the 8 that's more of a living wage, I would have to take 4 times more people. And then I'm not getting good care.
Right.
Like,
and the time that you have to spend doing the paperwork. It's a job in and of itself.
I'm buried. So it's a whole system that sucks for everyone, even the good midwives and providers and OBs who are trying to do the work within it. It really is. It's a beast to tackle.
I wonder if we could pivot to talk about federal policy. It feels like a little bit of a hard pivot, but it's actually related to everything all 3 of you have been talking about. So Ritual has been really outspoken in our support of federal paid leave. And also we supported the Momnibus bill, the suite of package of legislation reintroduced this last year, 13 pieces of legislation, I believe, aimed at starting to create some structural changes. We know that the changes in our hearts and minds also has to come in addition to these structural changes. But in addition to, and seeking kind of counsel from the 3 of you as leaders in this space, in addition to advocating for federal legislation like paid leave, are there other kind of federal policy pieces that we should have on our radar as a business who is unafraid to be outspoken and supportive of federal policy?
Maxine Waters just introduced a bill. I think it's called the Help Mamas and Babies Act. So there's leave or family leave for sure, but there's also childcare. Oh my gosh, childcare is like super ridiculous at this point in time. And then there are the other parts of the bill, just in terms of talk about the data collection. So we have numbers, and we know right now it's looking like a trend of health disparity is increasing as opposed to decreasing. So we really do need the data. And then what insurance covers also. So when we look at the Momnibus bill or Maxine Waters bill, we're looking at also there's a bill to expand federal aid to standalone birth centers. We tried to get that on the table in California, have not been successful yet, but we also want to expand federal funding to standalone birth centers. So we are trying to get there incrementally, but one of the things we talked about a little bit earlier was the pipeline in terms of medical system. How do we open up the system so we have more doctors who look like us, more doctors who are family-centered, more doctors who are community-centered, and how do we get them paid for in that pipeline, right? How do we expand the student aid? I'm so happy that so many folks are now getting their student loans forgiven, because trust, if you went through medical school You have some serious loans when you are enslaved when you come out of that medical school. You're not able to afford it. So expanding birthing centers and funding for both birthing centers, expanding funding for doulas, expanding child care subsidies, expanding personal leave or family leave are just some of the bills that are on and some of the provisions that are on the table right now in terms of federal legislation.
Yeah.
I also, my community organizer brain always turns on when we have this part of the conversation. I also think it's just as important as we support policy. We cannot forget everybody in these conversations. When we think about federal leave, we forget that a large part of like birthing people are tip laborers. And so like some of these protections don't necessarily extend to them. And a large part of people are like the birthing population. And so we have to like make sure that like we bring as many people with us as possible. And when we create policies, if folks are left out, we have to look to communities who are experiencing these issues and how are they resolving them on their own and amplifying that, hey, they have created their own channels and pathways, and what systems of monetary and like social support can we provide them to be sustainable.
Yeah. I am a dear friend of mine works for California Family Work Coalition, so she just tells me what I should be behind. That's kind of how I roll. And I know right now that pregnancy leave for educators is one of their, outside of paid family leave, which I think is their top priority, but specifically pregnancy. I don't know if you can hear that horn. I apologize if you can. Pregnancy leave for educators, so they're not exhausting their sick leave during their pregnancy, that they actually have additional leave and time off for things that come up in pregnancy. Again, for me on the micro level, I create space at 28 weeks for all my clients, birthing person and partner, to start the conversation with their HR. So we know what the game plan is, what I need to sign, what I need to get other people to sign, and how much leave can we milk out of this system that they're already paying for, specifically those who qualify for SDI. I always tell people just to start that conversation as soon as possible, because we know that people often don't know what they actually, their rights are, and then people often don't take all they can. And particularly my little push recently has been with partners, like take all the freaking leave. You going back sets it back for all of the birthing people in your office who don't have the luxury to go back at 4 weeks or whatever it is. So let the company figure out how to do without you, so that they have an actual system in place when every birthing person in that place goes out and they're not feeling pressure to go back sooner because the company's falling apart. So we have those little social justice plugs in my care, because that's the little I can do of like, this is how it moves the needle in these individual companies, that every person, whether you can't physically give birth or choose to, go back to work so soon, and the birthing person has to be out physically, but should be out too. So that's like the little things I'm doing, but aside from that, the policies I see are the pregnancy one for educators right now.
The other policy that is on a California plate, not on a federal plate, is around how incarcerated pregnant people are treated. They are way too invisible to many of our conversations, and that is one of the things we're trying to do, to make sure that there is humanity for incarcerated pregnant folks, that they get an opportunity to bond with baby, and that if possible, that they not be incarcerated until the child is at least a year old. Right. So some of the things that we're looking at, especially given the hostile climate that we are in today.
It's very well said. We are nearing our time this session, so it's been really awesome. I just want to take this time really fast to say thank you again to Sarah, Jessica, and Jeanette for your infinite wisdom, your raw responses, and wealth of knowledge that you shared with us. We really appreciate it. To close out, we just want to give you all an opportunity to do a plug on to the work you're doing again, some things to look out for, events, policies, etc. We know we talked a lot about that today, but just a couple of minutes to wrap that up and to let us know about some stuff you're working on.
So this week, starting yesterday, is Black Maternal Health Week. So we are celebrating throughout Los Angeles County with Black Maternal Health Week. This morning, we had a conversation on policy with our program called Sisters at 8. Today also, we're doing the tour. It's so exciting. We're going to Kindred Spaces. We're going to Maternity Center. We're going to a couple of hospitals. So people have they can lay eyes on different places where you can give birth at, so they'll have a more informed option about where they want to give birth. Tomorrow, we're doing a film showcase where we are screening films. This will be at USC about birth. It's about the birthing experience of Black folks. So that's tomorrow. We were going to have a community baby shower tomorrow, but please go to our website, bwwla.org, to find out more. Right now it's canceled because of rain, because it was going to be outside. However, you will find all of our activities for Black Mamas Week at our website, bwwla.com. .org. And if you go to any of our social media, which is the same BW with the number 4 WLA, you'll see all of our activities. So social media, that is Instagram, LinkedIn, Facebook, and X, formerly known as Twitter.
Just gotta let you go.
What am I saying? Sorry.
Oh, just to round out a shameless plug, your spot to tell us what you want. Yeah.
Got you. I am not doing anything as cool as she is doing in the world. I am delivering babies here and there. So I have a home birth practice at jessicadiggs.com. If you need some holistic midwifery guide, I'm at Moxie Care. Giving out PAPs and things and all, and listening to your needs. But yeah, I am in the community being a midwife. That's what I'm doing these days.
Love that.
Yeah.
I am studying to be a midwife, and I am in the community. I will be back towards the later end of the summer with more abortion, political, and care education. I've been working with the California Women's Black Health Project recently, and I've been doing some trainings in SoCal, and I'll be bringing some up here to the Bay and back in SoCal because I have to come soak up some summer sun. So you can catch me on Instagram as Birth in the Block, and I will put that in chat.
Yeah. Wonderful. Thank you again. Thank you, Lindsay, for co-hosting and your amazing questions as well. And with that, I think we're going to close it out. And I hope everyone has a beautiful Friday and happy Black Maternal Health Week.
Yeah. Thank you.
Thank you all.
Thank you for having us.
Yeah. Enjoy your time at Kindred Space, Janet. Tell